The topic I've chosen for this session is, it's quite challenging, I must say. Challenging to understand. It's a challenging topic because we all see patients with this. And not only it has been challenging, but it's been challenged by many. It's been challenged by, even now, there are people thinking of new theories on how to understand better this ulnar-sided carpal instability issue. So today I'm going to give my opinion or my view, if you wish, on how to deal with this subject, or how do I know that this is the way to go, because it's my opinion. They say that the ulnar side pain is the low back pain of the hand, but obviously it's not that. I mean, I have had myself low back pain, and I know that it's nothing compared to that, because you have lower pain, you lose a little bit of weight, and the pain sooner or later will go. So it's a different type of a story. It's a different type of complication what you have here. Because the prevalence, look at these numbers. Those comes from a recent publication. 98 per 10,000 per population per year are affected by this problem, hand and wrist. With the large economic and social repercussions, absenteeism is the usual topic. For things that people think, no, this is nothing. No, it's not nothing. It's a real issue. And you'll see the long list of diagnoses that we can make. Imagine it's a very difficult, aside from comorbidities and psychosocial factors, of course, but there are many treatments are being used without knowing what the specific diagnostic is. It's calculated about 32% of the cases all over, almost in all populations, don't get a right diagnosis, or specific diagnosis at least. And of course, whenever we are in these circumstances, the logical thing is that we have disappointing results. And this, ladies and gentlemen, this is the ulnar side list of frequent causes. And we are not talking about the thing like a little bit of scratch. No. It's really a long list of diagnoses, something about carpal, metacarpal pathology, etc. I mean, there's a lot to be said about the pain in the ulnar side of the wrist. Well, at least we could say that it's amazing that there are, in less than 5 centimeters of our wrist, there are so many frequent causes of pain. Not only the anatomy, we have other problems as well. Today, I would like to concentrate on ulnar-sided carpal instabilities. The difference between wrist instabilities and carpal instabilities, I think, it's just for sake of trying to make it understandable. Carpal instability is the one that is within the corpus. Wrist instability includes the RUJs, includes ulnar carpals, includes carpal metacarpal pathology as well. And if we want to include everything, we will not be able to do. So let's stay on the ulnar side carpal instability. For those who have been around for a while, they remember the columnar theory that the Julio Talesnik presented some time ago. And it's a columnar theory that he was using to say this is a central column as a model. It's a mechanical model, central column formed by the lunate, the distal row, and the proximal radius of forearm bones. Then there's the lateral column, escape foot only, and the right column, medial column, which is the triquetral. That was his idea, following the teachings of Professor Navarro from Uruguay, who in 1921 was the first to start talking about the models of mechanical models. Logically, the Julio Talesnik was led to believe that there was one type of instability that was ulnar to the central column, and the same he thought about the lateral column. There was another, which would be more scapholunate, scaphocapitate, and STT, a progression of dysfunction. And this is understandable. But the problem with this is that It's been challenged by many, but this needs to be challenged because it's not the same lunotriquetral instability as we will see today, and midcarpal instability as we also will see today. I mean, if you combine both in the same chapter, and his book was in the same chapter, everything discussed under the same prisma, of course, you didn't get the message, particularly because both pathologies look quite alike. The both tend to develop busy pattern of instability, and both of them may develop some type of clunking. So if you consider one and the other as if they were one single pathology, you are gonna have some trouble. On the other hand, there are some real instabilities in this area that have not been covered. For instance, the one that is quite frequently found in the cases where the triquetrum has been excised. You excise the triquetrum whether or not you have a radial-scapholunate or radial-lunate fusion, and sooner or later, particularly in the position of that throwing of extension ulnar deviation, extension radial deviation, you'll have a clunk developing, and it's one type of instability that has not been observed or has not been discussed right away. There's still another type of instability present whenever we use those partial radiocarpal prostheses, the partial, only the radial component. They have a lot of cases with some instability over there. So the subject needs to be challenged, and it's a challenge in itself. So let's face the fact and let's concentrate on the lunotriquetral dissociations, which are the ones that I think that deserve more attention for academical purposes. Maybe not for clinical purposes, because there are many of those that are there associated to these radial fractures, and they evolve very well, very nicely. So let's discuss today in this anatomy. We'll talk about mechanism of injury, pathomechanics, diagnosis, classification, and treatment. Anatomy. We have discussed that on the first session, but basically what I want to today to discuss a little bit is the proximal row. The proximal row is a row that was that appeared as something to produce to increment the amount of rotation of the wrist without having so much incongruity, to say something. So the proximal row scapholunate triquetrum, you can see here from one dorsal to palmar view, a little bit open, and then to the right we can see that distal to palmar view. Proximal row, here in a case that it's connecting the three bones, scapholunate and triquetrum, to each other, so that they form one. I was about to say one functional unit. No, it's three units, three functional units interacting one to each other, and they are interacting through these ligaments. This is the ligament between scaphoid and lunate. Again, now we have that fact that the dorsal scapholunate produces a yield strength much stout, much solid than the palmar one, while the lunotriquetral is the reverse. It's the palmar one, the one that it's more solid with the yield strength larger. We're talking about 350 newtons, which would be about 35 or 40 newtons, 40 kilograms for the rupture. So they are really strong. And this is an important one. This is a serial cut, an axial cut of a fetus that you can see scaphoid and lunate and the disposition of the fibers of the dorsal and palmar ligaments. And this is pertinent because these days there's been a lot of discussions on whether or not we should repair the polar ligament or the dorsal only, or the two of them. Probably the two of them would be a nice idea. But the thing is that I don't think we can treat the two as if they were one single transverse ligament. They are not even that strong all over. The dorsal scapholunate is very strong and stout, and does not allow that mobility. Well, the palmar one, if you look at the disposition of the fibers of the scaphoid to lunate, you can see that there's that obliquity always that goes from proximal pole of a scaphoid into the volar surface of the lunate. The fibers are much less, as we have seen in that paper from Maeda. The fibers are more elastic than the dorsal one, and that allows that scissoring type of motion that we need for this. On the lunotriquetral, it's different. It's different because the dorsal one, the dorsal ligament, the one that you can see here, it's more transversely oriented. It's not like here that they have that uh, obliquity that a long time ago John Coward has shown us. The palmar ligament is really stout. The palmar ligament really important one. And that explains why when you see those x-rays, flexion to extension, you can see that the scaphoid travels much more, rotates much more than the lunate to get to the same place. Why is that? Well, it's obvious because the radial curvature of the lunate and the scaphoid is not the same. And the scaphoid has a very short radius of curvature and needs to rotate much more to get to the same place as the lunate. So that explains that 32 degrees of motion that we can calculate or we can measure between scaphoid and lunate. Not the same on the lunotriquetral because we have said that the palmar lunotriquetral ligament is very strong and very thick, and it cannot behave as the one that it counterpart between scaphoid and lunate. This is strong, and the dorsal is not that good. That means that in the lunotriquetral joint, what we have is more translocation. We have more shift proximal to distal than in the scapholunate. In the scapholunate, we have that scissoring type that we have discussed many times. In the lunotriquetral joint, we don't have that. We have more a sliding motion between the triquetrum and the lunate, and you'll see why. This is one of the papers that we published a long time ago, in which we calculated how much displacement in the sagittal plane there was between lunate and triquetrum in normal population. These were more or less the averages of motion. You can see we tested 60 people, normal people, some of them younger, some of them older, was quite evenly distributed. And it was published in 2003. And you can see that the mean displacement that we have, the triquetrum relative to the lunate, is 2.4. Not much, but the changes a lot. The range is enormous. You can see that there are normal people with 5.2 millimeters of displacement. Not only that, but we found it was interesting because in all of them we calculated the global laxity score that we were saying. It's a score that provides you an idea of how lax were using them. And what we found was that the more lax the individual, the more the triquetrum moves. So the more play there is in the ulnar side. And the more play, the more injury can be, but also the more type of instability and maybe less type of stiffness or impactions. So there, to start with, we have a picture of the ulnar side that it differs from the radial side. The radial side is a load-bearing column, while on the ulnar side we have something that it's much more mobile, much more intimate. Probably Elizabeth Haggard, when speaks to us about the proprioception, she will explain why the ulnar column cannot behave exactly as the radial column. Here we have that increased mobility. If you have that increased mobility, the lunate is fixed, and you can see that in radial deviation, it's ulnar palmar flex with that moon-like configuration. On the right, we can see the moon-like configuration as well. That means that there is no much flexion extension. And the triquetrum goes up and down, and that produces hypermobility in the lunotriquetral. And that may produce that painful experience the people have, an ulnar styloid impingement if the ulnar styloid is long, or even meniscoid degeneration if there is some. This would be a schematical outlining the bone. And you can see really that in radial deviation, the triquetrum goes up, and in ulnar deviation goes down. That is the type of dysfunction that we can see. This is in one of those 4D CTs that we published some time ago, and it's a case where you can see that between triquetrum and lunate there's a gap forming palmally, and that means that there is an instability in that case. And the same case, it's on the dorsum, and you'll see that there is much more influence of the hamate hitting the lunate at the very last moment. It just derotates the proximal row from busy into a normal situation. Well, that's a little bit of general impression of this is an area that we know very low. Mechanism of injury. Well, we know more about that because basically most of them are young individuals that fall on the hand. Again, what we were discussing the other day on whether there was supination or pronation. In this case, is intercarpal pronation. This is a perilunate instability. And when we say intercarpal pronation, we mean that the forearm is supinating against resistance of the hand. What happens is that the patient he has an accident, he is falling, he gets the hand flat on the floor, and the floor it produces resistance, and the body is flying on that fixed hand on the floor, and that is what makes all the damage. And also, you know, this work by Mayfield, you know that the lunotriquetral dissociation is the third step, and the third step you can see that there is a pulling of the triquetrum relative to the lunate. The lunate remains there a little bit, as we said, for this scaphoid, remains there because the volar radioscapho short radiolunate ligament is very strong, and the ligaments between the lunate and triquetrum are solid, but not that much, and it fails. This is a case in which we can see that there is a doubt on whether there is a scapholunate dissociation. This is not the scapholunate dissociation. This is a true static lunotriquetral dissociation. As you may see, it's a reverse perilunate instability. And reverse perilunate instability means that the disruptive forces start on the ulnar side and produce that type of disruption towards the radial side. Less dramatic than that, we have that typical fall backwards where there is an axial loading on the hand. The hand is on the back of you, and external rotation. You land over that, have axial loading, external rotation, and ulnar deviation. And in those cases, exactly where the lunate is protected by the radius, but the triquetrum is not. And in that situation, you have that shear stress, sagittal shear stress between triquetrum and lunate, and this is a much, by and large, much more frequent type of pathomechanism for most of lunotriquetral dissociations. Needless to say, this can be associated to distal radial fracture. Of course, you know how many cases that you have a distal radial fracture. If you look or you scope that rays, you find that there is also lunotriquetral dissociation or disruption. The pathomechanics of these, what happens whenever we have those ligaments disrupted? What happens to the rest? Those are the studies that we have elaborated from some time ago. This is two that we happened to do at the Mayo Clinic. One was with Emiko Hori from Japan, and later with Marco Reed from the Netherlands. We did a work that basically what proved that work was it's not like a scapholunate dissociation. It's more than that. I mean, you need more injury to get the same type of result. If you only do a stage one to the left, that means that you are only cutting the intrinsic ligaments. You'll get almost nothing. For the wrist to collapse and to have the absolutely rotation into a VZ, you need more than that. You need the extrinsic ligaments disrupted as well as the ligaments. And these were the work that we published, in which you can see that there are basically no differences in motion if only the lunotriquetral ligaments are disrupted. Well, if you have then added, if you had all the extrinsic ligaments disrupted, basically the long radial lunate and the radial lunate and triquetrum, that bridge that there is, and also you need to have the dorsal radial triquetral ligament disrupted for that to happen. And then you have the complete story of a lunotriquetral dissociation, carpal collapse into a VZ situation. So in a way, what we learn from that is that the difference between this and this, it's not as much that there is normal ligaments. No, the ligaments, intrinsic ligaments may be absolutely disrupted. But as long as the lunate is contained or has that wall, dorsal wall by the dorsal capsule and the dorsal retroquetral ligament intact, you cannot have that static dissociation. Well, if you have that disruption, then you will have the static dissociation real soon. And it is, by comparing this with what we were discussing the other day, um, instability in those cases probably should be referred more precisely onto that point where the triquetrum is about to collapse, migrate proximally, and the lunate and scaphoid is about to collapse into a full flexion. That would be the moment of maximum instability or clinical instability. And the rest is more like a sprain. It's like pain producing. I'm not saying that there is not pain, but radiologically, you cannot see much. The second study that we have done, this is quite recent. We have done a study in the lab in which we have tried to see what was the mechanism of muscle control of lunotriquetral dissociations. That was done with Maite Leon, a PhD now in Mallorca, and she did all the work and we helped her in defining how could we produce that carpal collapse by sectioning the lunotriquetral ligaments. And we did it in 10 specimens. What we found was absolutely right, or it matched very well with the work done previously with the scapholunate. If you have a lunotriquetral dissociation, and if you have the issue acting, what you have is a reduction of the lunotriquetral joint. The lunate and triquetrum, by just pulling on the issue, they go to the place. Not only that, but also you can see that the VZ pattern, we are looking at the specimen from the back, that VZ pattern is reduced. So this is good. I mean, the issue that it was so unfriendly with the scapholunate ligament is friendly for lunotriquetral ligament, and it's friendly for the scapholunate, unfriendly for the scapholunate. And the reverse is also true. I mean, if you in those cases use, instead of the pronator, which is the issue, you use the supinator, APL and ACL, what you have is that exactly clunk. The clunk, it's so easy to produce by just sectioning that and using the supinators to close that gap. You are not closing the gap, you are producing much more gap, and you are inducing more VZ pattern of instability. And that helps us to understand then what's going to be the treatment of choice for the patients with a partial tear of the lunotriquetral joint. How can we diagnose lunotriquetral? Well, this is the development test. You all have learned that, and probably Carlos one of these days will teach us how to do the development test. Is about can be done at 2 hands, 1 hand, according to Dr. Clayman. And this is interesting because Gilula's lines, we all have learned that from when we were residents. Gilula line, they were the line number 1, and this case that it's a static VZ. Obviously, we have that a little bit of, not a little bit, though, we have that step off, clearly step off is there. Gilula line 2, there's no much on it, and Gilula's 3, it's a proximal outline of capitate and hamate. There's no much information on that. In my opinion, I think that Lou Gilula should have included this one. This line is exactly the line that covers the dorsal outline of this. And this is where you can see that the V type of a clearly pathologic alignment between lunate and triquetrum. It's a Siegel sign that we call it. Siegel sign meaning that you have that V type of outline between lunate and triquetrum. This is pathological. Whenever you see that, you have absolutely for sure that there is a lunotriquetral dissociation. Well, if you have a volar placed non-dissociative proximal row, there will never be that precise or that sharp signal sign. So this is the signal sign. Remember that animal that that's fly over Barcelona many times a day, and they are shitty because they're like rats with wings. Anyway, I'm sorry to make this comment. Here you can see then dynamically, if you take the dynamic X-rays, you can see that the lunate again fixed in that fixed position. Scaphoid, it's always a palmaflex. That means that it's shortened, foreshortened. The lunate has that moon-shaped configuration always, and it's a triquetrum, the one that goes up and down. And that is also pathognomonic of a lunotriquetral instability. What about these angles? Are they easy? No, they are not easy to trace. The angles for lunotriquetral were defined by Regan with Ron Lynchite at that time and Jim Doggins. And this is just for academical purposes. Probably you'll get to see that. But what it's important, it's not whether it's 14 degrees or 13 degrees or 17 degrees. The important thing is that in the normal population, we have the axis of the triquetrum. It's always palmar with the lunate. The lunate, it's always dorsal. I mean, if you trace it using the tangential axis way of tracing this. And midcarpal instability is the one that proximal row goes everything into palmar flexion. What you have is the triquetrum axis is always palmar to the lunate. And if you see that it's not the right, I mean, if you see the triquetrum going dorsal, that's lunotriquetral dissociation. So I don't care whether it's 14 degrees or 20 degrees or 50 degrees. If the triquetrum is palmarwards relative to the lunate, that means that the scaphoid is bringing the lunate into flexion, and the lunate, the not dissociated lunotriquetral joint, is also there pulling the triquetrum into flexion. Well, if there is an instability, we know that it's disconnected over there, and the triquetrum goes into extension, and that explains everything. So this is not a completely useless method. What about the stress test? Well, it's been Ono and Gilula described that the fact that you may translocate distally the distal row dorsally, and if the triquetrum stays with the lunate, it's a lunotriquetral dissociation. And if it stays behind if it stays behind together with the lunate, this is midcarpal instability. And if it travels together with the distal row, then it's lunotriquetral instability. Again, as usual, whenever in doubt, no doubt, go and scope the guy, and using this technique of using the optic or using the proof, and if you can rotate it and so on and so forth, you will get the diagnosis. How to classify those injuries? Classification, it's another subject that has been challenged and challenging to me, sometimes even to know whether we are in stage 1 or stage 2. Classification, there are 4 types, and that was described long ago by I forgot. Anyway, there's a dynamic and static dissociation. We have mentioned that. Dynamic lunotriquetral dysfunction is whenever we have the intrinsic ligaments disrupted, but the extrinsic ligaments are still there. The secondary stabilizers, they maintain the alignment. The alignment is okay. Lee Osterman, excuse me. Lee Osterman was the one who made that description or that typology. Static is when you have that collapse. The lunate has that moon-shaped configuration, shortened scaphoid, and the triquetrum has been migrated. Proximally, this is static. Type 2. The type 3 is whenever we have both the scapholunate and lunotriquetral dissociated. That would be a perilunate dislocation. Or perilunate instability. And finally, we have the type 4, which would be the case where And ulnar abutment has worn so much the proximal membrane of the lunotriquetral joint that it's been disrupted, and it may end up being unstable. This will be an open, long time open technique for uncover the lunotriquetral joint, and we found that in radial deviation it opened like a mouth, and you can see the that place that there was a dissociation, there was an instability here. Obviously, nobody would do that nowadays. It's an approach, an excessive approach, but it's a good example of what a partial injury will be. And this will be type 2 evident. Again, we have that all the characteristics of a static VZ. And this will be the characteristic of a perilunate dislocation. We can see that proximally the lunate that this is located, it's far away from the triquetrum, and that indicates a lunotriquetral dissociation. Here you have an ulnar plus type of ulnar variance with that signal intensity change in the proximal lunate that would be typical for this situation. And then the treatment is easy because, well, you know, if you have a type of 4, if you have a ulnar shortening, you shorten that, and you'll have that solved by just shortening osteotomy. But see something that I like always to emphasize. Whenever you are shortening the ulnar, you need not to shorten too much, but also in many cases, you need to check on the radius styloid scaphoid interval. And sometimes you need to make a small radius styloidectomy. Why? Because usually whenever they have a long process or chronic case of an ulnar very long, then you have that tendency of the patient of working with the hand in radial deviation. They have that poor, impingement there. But in this case, I don't know if you believe me, but there's a little bit of fracture here. So by performing the ulnar shortening, I always do a little bit of a styloidectomy, and that helps. Type 3, it's a perilunate dislocation. You know that in those cases we tend to use or salvage procedure almost always, particularly if that's stiff, but it's very much a well reducible or easily reducible. You may go into another idea, which is the spiral tenodesis. Today it's not the day to discuss that, but it's a case that it's increasing the type of the number of patients that come with reducible types of instability that can be solved, and that could be one that we have been very pleased about. Type 2 is a case where you have a static VZ. Static VZ means disaster, means almost the same as we were saying the other day about the scapholunate dissociation. One thing is that sailor that it's in the ocean, that it's fighting against the waves, and he needs help back then. But if you wait a little bit longer, what you have is completely destroyed the boat, and now what you have a VZ, and the VZ cannot be solved by just soft tissue injuries, soft tissue answers. You need even the lunotriquetral fusion. You have a lunate that it's in VZ. If you add that by fusing the lunotriquetral joint, everything fused will go into flexion again, and you'll have the situation that we had in this case. We had to go back and do a formal midcarpal fusion to get relief of that pain. This is by Ricardo Lucchetti. I don't know if today it's on the audience. The other day it was. Now he did exactly the same. He had that. He tried to do all the reconstructions that he could, and for a surgeon, a good surgeon like him, he could. But it's impossible. I mean, it's too much. It's too much. The forces in static VCs are so great and so destructive that you cannot do that by just repairing ligaments or repairing capsules. The same in another case that was courtesy of Dr. Tordai from Sweden. He did the same. He did that solid fixation between lunate and triquetrum, but that was not enough to correct this. So whenever you have that type 2, probably it's to go into some sort of salvage procedure and go ahead. Type 1, it's there's something more intriguing here because it's a source of pain that usually goes undetected, and sometimes more than 30%, as I said in the beginning. And they say, well, this is almost wishful thinking, because to find the proximal membrane and to find it and do that repair that was a long time ago, made this drawing. I think that that's not true, but it is true on the volar side. The lunotriquetral ligament on the volar side, we have said that before. Lunotriquetral, it's very stout, very strong, and it can be repaired perfectly well through a volar approach. In the case that, in this case, was one of those perilunate dislocations, and we could make a good repair. And by doing that, aside from eliminating any incarceration of soft tissue into the articulation, it helps a lot. So remember, the volar ligament, lunotriquetral, is repairable, and the same for the dorsal ligament, scaphoidal ligament, is repairable. And if you do that, as we said the other day, you are doing right thing. Lunotriquetral has another different relative to in relation to the scaphoidal joint, is that it's so well vascularized. It has so many vessels entering the two bones from both sides that no matter what you do, even in cases like this, that we only just reduce and we place a couple of K wires across, it's fused. So it's one of the fusions that it's so easy to perform, and the problem is what you get then. We'll discuss that later. But you see that this is by Liostam and Simon that they presented 20 dynamic lunotriquetral instabilities. All of them were arthroscopically diagnosed. The typical sprain that you go there and you don't know what to do and say, okay, that there's that you can prove the proof get inside of the joint, and you can do everything. They say, okay, let's place one percutaneous K wire, and most of them are doing very well. As long, so that's the good news. The good news is that this is a joint that it's difficult, challenging as you wish, but the repair, a partial tear, it's not difficult. And then you can go like in Watson's paper. That's first author Guidera, but actually it's Watson, and he was claiming just to open the joint, and you open the joint and just clean the inside of the lunotriquetral joint, remove some cortical bone, create kind of a cave inside of the joint, fill it with a cancellous bone, and you may place one, 2, 3 K wire, or may place a screw or whatever. The important thing is that you need to treat always the DRUJ, because in many cases like this, well, what you have is that once the triquetrum is fused to the lunate, it's getting all the stress that it's getting the ulnar side or ulnar corner of the lunate, and then you have an ulnar carpal impaction, and this is why this is not a good idea to do. I mean, the fusion, it's nothing that can be done without paying some penalty. Otherwise, look at here in this series, you can see 61% of painful breasts after surgery out of 164 patients. And it's a lot. I mean, and too many non-unions, and that's why we are not that happy with whatever we have seen on lunotriquetral fusions. And that's why I think Alex Sheen and Alan Bishop from Mayo Clinic, they also thought that perhaps there was the option of doing a tendon reconstruction. They proposed that technique. It's a technique. There are others. I know that John Stanley, he produced another one, similar one. These they go just like a loop about the triquetrum into the lunate, and this is a case that, well, this is a representation of how it does. You have a strip of ECU, you pass it across the triquetrum into the area where the palmar lunotriquetral ligament is, and then across the lunate into the dorsum again, and you close it this way. This is a case, and these steps one after the other of a case that I did some time ago, and I couldn't follow him because some other problem with him, and I don't know exactly how it went. I know that has been lost for follow-up, but it was a good example of how this technique works. And always remember that the only way to dynamically reduce and stabilize the BC, again, is to co-contract the ECU and the FCU. And if you have an ECU contraction, you have a reduction, and the FCU muscle, it's ending with that instability. So remember that there's a lot of things to be said about this problem, but most of them can cure or can go ahead or can get along with their problem by just doing a muscle reeducation of the ECU and FCU in the right environment. Well, ladies and gentlemen, this is it as far as lunotriquetral. Maybe it's a little bit too late, I don't know. But let's continue. I would like to show you now the other aspect, the other pathology that looks like that they also have that VZ, and they also have that clink or clog, and are taken as lunotriquetral dissociations very often. So let's go and discuss proximal row dysfunction. Why we call a proximal row and not midcarpal? Well, because the midcarpal rotation, whenever you have a proximal row that it's a non-dissociative, that means that the proximal row lunate and rotatum, although although lunotriquetral will rotate as a one, what you have is also these kinematics distal at the midcarpal joint and also proximal. I mean, and you cannot imagine something that rotates badly on one side, that it's not a bad rotation on the other side. That's why we propose, and actually was Dr. Bright, the one that proposed it, that to call those instead of lunotriquetral or midcarpal or palmomidcarpal, or midcarpal, to call them proximal row dysfunctions. As an introduction, this was described by Ronald Insight and James Dobbins. It was two patients that they could see that could voluntarily sublux their wrists. And I like this expression because it's to the amusement of friends and consternation of doctors. If Jim Dobbins and Ronald Insight were consternated by this, it was really difficult. And yes, that was the case, and the case where they have the clunking wrist. Look at that whenever it goes into ulnar deviation, it's whenever the wrist is aligned, and in radial deviation, there is that typical sag that is from in this case. Remember as well that for long periods of time, all the malalignment was always said that to be unstable. And this was something that Yves Allieu from Montpellier, he did a good job by telling us those are not instabilities, even though they are malaligned. It's a malaligned or misalignment that it's adaptive. It adapts to a situation that in this case would be distal radius. In those cases, by just performing correct osteotomy of that distal radius, you have that reorientation of the bones. And this was not to be taken as unstable. Otherwise, they got a lot of procedures that were useless, that did nothing. That was a good accusation by Yves Allieu. I think that he needs to be remembered about that. And not only that, but also the fact that not only the midcarpal ligaments are okay, or not only midcarpal ligaments according to the oval ring theory of David Ligament are fantastic and need to be okay to understand the midcarpal joint mechanics, but also the radicarpal ligaments need to be there. And if we lose control of those radicarpal, we are gonna have again all these proximal row instability. So let's call it proximal row instability or proximal row dysfunction. And then we'll have the entire picture obtained that in which the midcarpal joint is not working properly, but the radicarpal joint is not working properly either. Pathomechanics. There are two types of proximal row instabilities. One is the palmar one. It's the one that gets stuck in neutral and radial deviation and gets realigned in ulnar deviation, while in the dorsal pre, that dorsal proximal row instability, is that the dorsum of the proximal row is not protecting the capitate from subluxing, particularly in ulnar deviation. See, now it's in ulnar deviation, and the capitate can be subluxed very easily, and that's what Professor Johnson and Carrera discussed long ago, and they say that this is the so-called clip capital lunate instability pattern, or dorsal pre in that case. What's the difference between one and the other? Well, you know that in regularly, in a neutral position, the proximal row is in neutral. As you go into radial deviation, smoothly goes into flexion. And while as you go towards the ulnar deviation, you have that flexion. So flexion on the radial deviation, extension on the ulnar deviation. What happens with the dizzy pattern, the syn dizzy, is the one that it's behaving almost exactly the same as the other one. It's normal in radial deviation, it's normal in neutral deviation, and then ulnar deviation suddenly jumps and dislocates. This would be more a VZ type or Palmar type of a proximal row instability, in which there is always a VZ. It's Palmar flex in radial deviation, in neutral, and as you get to the almost the extreme of ulnar deviation, you get that force producing inside of the bone and jumps up and reduces. It's a typical catch-up clunk. Catch-up clunk, also known as palmar midcarpal instability or syn VZ. Again, let's review that. It's in radial deviation has that little bit of, well, not a little bit, you have that VZ producing proximal row, although proximal row is in flexion. In neutral still is flexion. In ulnar deviation, it automatically jumps into a reduced position or clunk. And the dorsal is exactly the same as before we have said, that radial deviation is normal, neutral is normal, and then in ulnar deviation you get that dislocation so easily in ulnar deviation, and there must be something related to the dorsal capsule and the dorsal scaphotroquetral ligament that it's hiding, or it's not allowing the capitate from sublux. Why does it clunk? Well, we have mentioned that many times. It clunks because there's an equilibrium disrupted between the flexion and extension. I mean, in radial deviation, you have the force produced by the trapezium and trapezoid on the scaphoid. The scaphoid tends to go into flexion, and that means that everything else, the lunate and triquetrum translocates towards the ulnar side, and that goes into flexion as well. So we have radial deviation. We know why the lunate and triquetrum goes into flexion. In ulnar deviation, it's the reverse. The hamate, it's the one that it's pushing the triquetrum, and the triquetrum is the one that then you have, again, if the ligaments are okay, you have that extension of the proximal row, extension of the lunate, and extension of the scaphoid to fill the gap between the distal row and the radius. Those are the ligaments that may be responsible for that, making that the dual flexion on one side, extension on the other, to make it smooth. Because we have said that two extremes we have that mechanical problem of the compression, but in the middle we have nothing. And to have nothing, we need to understand that there are ligaments. The ligaments are not that important in the sense of being cables. The ligaments are there just to pull the triquetrum and to pull the scaphoid into extension here. And we have the dorsal retroquetral ligament as well. So and imagine if you look at the list of ligament, dorsal retroquetral, STT, SC, and troquetal capitate ligaments, palmar, all those are the ones that are very much connected to mechanoreceptors. And the mechanoreceptors are there just to control that thing. Because it's not the ligament, the one that extends or flexes. It's the ligament, the one that informs what's happening on the ulnar column. And what's happening is that the ECU and the FCU need to contract. And the more they contract, the more you align them. And these are long time specimens that we tested for these, and look at the bisectioning the triquetral hemicapitate only, we could produce a catch-up clunk, meaning that clunking that we have seen before. Well, by just pulling for the issue tendon, we were controlling very well the fact that you could not dislocate that in a catch-up clunk. So in a way, what we are trying to say is that this is it's very, very difficult, challenging. I mean, this is not easy to understand easily, but we have the idea that for that clunking to occur, you need something wrong in the ligament and something wrong in the neuromuscle control of proprioception. So you need inadequate proprioception on one side, and you need also congenitally lax or post-traumatic disruption of several ligaments for that to occur, for the catch-up clunk to happen. And I could show you now some of the later cases done by Alex Luke, who's about to present his PhD on this very subject, on how to produce in the lab, how to do it reproducibly, reproducible catch-up clunks in the patients. Oh, no, sorry, in the patients, in the specimens. How to diagnose proximal growth dysfunction? Well, we have that, you all know, and this will be discussed. In ulnar deviation, you may translocate distally and you have that clunk. This is the pivot shift test that was described by David Ligament. You have that volar test that you are producing, that yawning sign for to know the palmar midcarpal ligaments in this case, to know how good it is the STT ligament. You use that maneuver to open the mouth. And the treatment, well, there are many treatments. Let me skip some of them because there were the initial, as usual. They thought that the initial thought was that it was a midcarpal, only midcarpal problem, and by just fusing the triquetrum to the hemet, you had that solved. And that's what we did a long time ago on the patient. This one was by Mireia Splugas as well, and we had that feeling that you did not, and very useful because, as you can see, the scaphoid, once the triquetrum is fused, scaphoid behaves as a distal wall, and you have that impingement, and you have that problem as well. So midcarpal fusion is not alone as an alone problem. As a lone solution, it's not a solution. It's just the delaying the problem for more, and for later on. Thermal capsularaphy is another possibility. I'm not that keen on that because I've learned from the big joint guys, and they say, well, for a while it may help, but due to the recovery of those tissues, we should understand that most of these tissues are not normal. Most of those tissues are hyperlax with type 3 collagen fibers. And what you're doing with this is just having a transient stabilization that it's not real, it's not permanent. With some trials and trying to find a good tendon reconstructions for the volar triquetral capitate ligament and also radius triquetral ligament. Well, you have seen that, and probably because I don't want to tire you much on that. I would say that this is something that may work if easily reducible in young individuals with like a case like this in which there's a unilateral clunking breast. In this case, probably you could do that, and you could do it in a way that it helps. This is 2 years down the line, the patient is stable, it has and all the clunking will disappear. But this is not what I want to show you. Because in the end, when we learn from Julio Talesnik about his results on radial fusion, he was saying, oh, believe me, the partial fusion between radial lunate, it's much more efficient in many different ways. Pain relief is excellent. Preoperative range of motion is maintained. Well, actually, it's not maintained, but you are losing sometimes less than 20%, 20 degrees of flexion extension or the whole carpus. And he was indicating something that we have to learn, is that sometimes radial fusion is the way to go. This is a case in which we did that fusion, and we can see that there is a dart throwing. Dart throwing is normal. And this case also another hyperlax individual, young individual, we did a radial lunar fusion, and it works very well, even in dart throwing conditions. Well, I think that's all I wanted to show you. Just to summarize, I think that this is a challenging. It's a subject that has been challenged a lot, but also is a challenging topic. I mean, I don't think we have a clear vision of what's going on. And precisely this is one of the papers that I wrote some time ago. Not that I'm ashamed of it, but it serves you as a point of as an anchor point for you to understand that this is more difficult than we thought. And what we should do is always take this as a personal view, never as the truth, because the truth is much more difficult to gather. So thank you very much again, and I think that that's it for the ulnar midcarpal, ulnar carpal instabilities and dysfunctions. Thank you very much.